Okay, it's 1:05. We might as well get going. Our moderator today, Dr. Lee de Clifford, is having a few technical issues, so he's going to try and get on at some point. So I'll hand over to Dr. Andrew Watts and Dr. Tracy Turner. The format of today is they'll run through a few cases and what they do in practice. Then we can refer to some Q&A session afterwards. If you just use the chat function, I can turn your mic on and we can have some speaking later. But otherwise, I can just read out questions as needed. But yeah, I'll hand over to Dr. Andrew Watts to start, and then followed will be Dr. Tracy Turner.
Thanks very much, Matt. You can hear me okay? Okay, so Palmar Foot Pain advances and updates in equine podiatry. So next slide, thanks, Matt. Okay, so Palmar Foot Pain, for the purposes of this particular lecture, focusing on, from my perspective, navicular syndrome and navicular disease, defined as inflammation or degeneration of the navicular bone and its surrounding tissue. Most importantly, the surrounding tissue, I suspect. Okay, next slide, thanks. Okay, so navicular syndrome, it's a very complex clinical entity to diagnose. There's a whole lot of different techniques we use. We'll go through some of those, and probably I just want to highlight videos are important for monitoring. We use a lot of videos. We take videos on case presentation. Then we take videos after we've shot up the horse here at the clinic, and then we pass on to the owners. So every week they get used to videoing the horse in counterclockwise and clockwise, lunging in deep sand and on straight. That continues for quite some time. But yeah, videos are highly important. Next slide, thanks, Matt. So in your clinical examination, testers, obviously hoof testers, I think it's really important to be able to get a handle on testers, be comfortable underneath the horse with testers, and to get the right responses. In this particular case, obviously, we're looking at across the foot testing for navicular and around the toe and heels and frog. We also use, and obviously, comparing left to right, going back and if need be, and reaffirming your responses. We use a lot of hoof blocks, toe, medial, lateral, and frog. It surprises me still to this day how differential the results for hoof blocks are. We can have a horse that's 1 out of 5, and then with a medial block, with a medial toe block, we're talking about a 2 centimetre wood block here, and that a medial block might trot off 2 out of 5 claims. So really important to take the time and use the hoof blocks. Obviously, then we go into imaging and radiographs. We take extensive radiographs, different angles, particularly the navicular bone, and we feel we're only getting about 40% of what's actually presented clinically. So we use ultrasound in cases where we can, but radiographs are only showing about 40% of the damage that we're seeing clinically. So diagnostic nerve blocks. So we tend not to, in our particular scenario, the horses are often referred to us from multiple different veterinarians. So we've pretty much localized where the lameness is. So we tend to avoid the nerve blocks because we have a farrier facility here. So we'll shoe the horse according to the radiographs and then reevaluate the horse. And obviously, if we've blocked the horse at that point, we can't see any significant difference in, in clinical response. So we feel that usually 2 to 14 days is the documented results between shoeing changes and mechanical changes to the foot, but we often see them almost instantaneously. Next slide, thanks. So just to run through some clinical cases, this is just a case with quite obviously an enlarged synovial fossa circled there. And, this horse is a 3 out of 5 lame, quite clearly not much radiographically, but there's obviously a fair bit of soft tissue inflammation with this horse. And he responded really well to our treatment protocol. And just next slide, thanks, Matt. Versus a horse like this, which has multiple synovial invaginations. It's quite radiographically apparent. both this horse and the other horse responded well to our treatment protocol. So varying degrees of radiographic change. Next slide, thanks, Matt. So here's just an MRI. Sorry, just back one, Matt. Forward one. No, I missed one. Okay, so there's a just back one to the MRI shot. Thanks, Matt. I don't know what's happened. It's deleted. Okay, so go forwards. So this radiograph's obviously got severe medullary changes, as well as see on that sagittal ridge, a deficit in the sagittal ridge. And sometimes it's hard to pick these things up. You've got to take multiple views, but the yellow line, yellow arrows obviously indicate medullary changes. You've got that crescent-shaped lesion with a deficit on that sagittal crest. Again, this horse was came back into competition mode. It was nearly 4 out of 5 on presentation, but responded well and is back at work. Next slide, thanks, Matt. This is the MRI. Okay, so MRI, this is a thoroughbred racehorse. You can see on the left there the arthrosis around the enthesiophyte formation around the navicular. On the right-hand slide, you can see that fracture. This horse that was diagnosed in February this year, and this horse is back in work and hopefully should be racing next month or so. So they do respond to therapy. Next slide, thanks, Matt. Here's another one. It's indicated by the 2 red arrows. You can see you've got a nice navicular fracture there on that palmar surface, flexor surface, and this horse is actually a champion barrel racer. It's now 2 years subsequent to initial presentation, and he's competing successfully. So these historically been very challenging to deal with, and nowadays we're finding some nice results. Next slide, thanks, Matt. So what's our approach? We have a 3-phase approach. We have a mechanical, a nutritional, and an intra-articular approach. The mechanical approach, next slide, thanks, Matt. So a mechanical approach is most of these horses present with a negative PA or a 0 PA, and with basically a broken back P1, P2 axis alignment. So what we tend to do with these horses is try and get that P1, P2 axis well and truly aligned, and usually that involves a fair degree of elevation of our PA. So we achieve that with different forms of prosthesis, whether it be a wedge or whether it be building up the superfast, but to get that elevation where we need it to align that P3 axis. So we also pull back the breakover. We pull back the breakover right to the tip of P3, and we radiograph them to ensure that is the case. And then we sole pack them with core support. We use sole pack CS, and the sole pack CS, they often present with quite a concave sole. So I feel that the sole pack CS assists in that support and helps that contracted heel, helps support those contracted heels. We only fill the sole pack to the inner margin of the shoe. Any further than that, we can get concussion through the frog and negative side effects. At the moment, we use an open heel shoe. We have been using alloys for a while. In the last couple of years, we've been transitioning to polys. The poly shoes have had some, they're very usable clinically, and we can adjust our breakover point. They seem to add a whole lot of concussion relief to the foot. Next slide, thanks, Matt. So here's a nice example of what we're typically presented with. Here we've got a slightly positive PA, but obviously clearly a very broken back P1, P2, P3 axis. So we'll probably jack that heel up probably 5 mil to start off with, and then re-radiograph it, see where our breakover is, adjust that shoe as needed. Next slide, thanks. So this is one of the polyurethane shoes we've been using a lot lately. We've chosen this shoe because of its concussion capacity, but also because it's really easy to rasp that toe off. We can square that toe off and pull that back post shoeing in situ on the horse, so we can get that PA exact. We can get that breakover exactly where we need it. And these shoes have proven very successful. We'll have the same horse on an alloy shoe with very similar balance, and not respond clinically, and yet they'll respond clinically to these polyurethane shoes. So they've been a real game changer for us. Okay, next slide, thanks. And obviously that's just the sole pack CS that we're using. again, we're very careful not to put too much. If we fill that that sole too much, we can apply too much frog pressure, and too much frog pressure inadvertently can cause discomfort. So we've got to be careful there. We just tape up the heels and fill it to that end of circumference. Next slide, thanks. So the next thing is nutrition. So we've just talked about now, obviously increasing that PA for these horses to get back into sort of effective work. We need to get them out of the prosthetic elevation. So we need to remove either the wedges or whatever we've used to jack that foot up. And we use either total bone or hoof gold. We've found that instead of getting 2.5 to 5 millimeters per 30 days, we're getting 10 to 14 millimeters of hoof mass, extra growth. We've been able to radiographically prove this again and again. And it just gets us back to a normal foot quicker. The quicker we can get into a normal foot, obviously, the quicker we can get this horse back into work. Okay, next slide, thanks. So then obviously we're talking about the intra-articular phase. So historically we've used a lot of different sort of corticosteroids, and we've drifted away from that, and we've been using hydrogels. The only hydrogel available on the market here in Australia is Arthramid. So we usually, on presentation, we do the mechanical changes with these feet, these patients, and then we reevaluate 4 weeks post-shoeing. And at 4 weeks post-shoeing, we can see how that foot is growing. Number one, we can see the response clinically, whether we've had a mechanical response. And if we're failing to get the response that we need, we do our first intra-articular injection. So when we do this intra-articular injection, I'm using a 21 gauge, 1.5-inch needle, and I'm going just maybe 10 mil dorsal of the coronary band. Some of these horses get an incredible amount of joint pressure. So, in placing the needle, you quite often get a trickle out of the hub of the needle, but I just do one syringe, and I do it always bilaterally. Quite often these horses show up, although we don't block them out. If we're having frustrations with it, we'll block them out on the most lame limb, and they will go contralateral lame. So we always treat left and right simultaneously. And then we do a second intra-articular dose at the third shoeing, so another 4 weeks' time. And usually that's all we require. Usually those horses do respond very well to that, and they don't require a third dose, but each patient is very different. So, okay, next slide, thanks, Matt. So I've just thrown this one in as a hydrogel suitability. It's a bit off base, but it is involving obviously the coffin joint. This is a fracture that's 2.5 months old that was presented here. And it's obviously an intra-articular fracture, and I'll just throw it open to everyone's suggestions on whether hydrogel would be suitable for this and whether we could get some additional healing capacity in that intra-articular site. So that's probably it for me, and I'll hear the questions and answers from later. Thanks very much, Matt.
Okay, my turn. So my approach to these cases isn't much different than Andrew's, but it's slightly different. So as Andrew indicated, there's a lot of different things that go wrong here. We always just say the navicular bone, but I like to consider all those soft tissues that we're talking about. So yeah, so navicular osteitis, probably the one everybody talks about, but in a study we did a while ago, we found about only half the cases or less could be referred directly to the navicular bone and its adjacent structures. And otherwise, some were on the coffin joint side and some were on the bursa side. But a lot of different structures. So you can have the bone involved. You can have the deep digital flexor tendon involved. You can have the insertion of the deep digital flexor tendon. You can have a bursitis created by damage in that. So it's just an inflammatory response in the bursa. You can have distal interphalangeal arthrosis, oftentimes occurring from strain to the joint capsule or strain to the collateral ligaments. You can also have a navicular bone fractures that the distal border fragments were quite clearly shown by Andrew's radiographs. But that's not it. We can also have Desmopathies, the proximal suspensory ligament, or oftentimes called the collateral sesamoidean ligament. You can have a desmopathy of the impar ligament. You can have sole bruising, because remember, these cases are all, what's similar about them, they all block to a palmar digital nerve block. And they all can present with very similar clinical signs, even in marginal third phalanx fractures. So depending at the time you get these signs can be slightly different. So whenever I look at a case, I keep all these things in mind. My approach to the diagnosis is, number one, go ahead and click on that. We do an examination for pain, very similar. I want to run through manipulative tests, jog the horse back and forth, go to hard surfaces, soft surfaces, and see if I can differentiate what the horse is feeling there. Next. Then we're going to move on to the response to diagnostic analgesia. Now you have basically down here in the distal limb, you have three areas that we're interested in. We can be interested in the coffin joint, we can be interested in the navicular bursa, or just a nerve block that takes everything out. That's the palmar digital nerve block. So depending on what's been done before will depend on what I choose to do. Then I always have an examination for hoof balance. I want a complete assessment of looking at that foot clinically and then also radiographically, so I know how the bones actually sit inside that hoof capsule. And that obviously is going to require some sort of imaging of the equine digit. Next. So my examination for pain. As we look at it, these things are going to be a series of different manipulative tests. And go ahead. So these will include the distal limb flexion. They will include hoof testers and percussion. I find percussion, especially if you're looking at capsular problems, picking up the pain, the hoof testers can do the same thing, but that percussion can tell you a little bit about some wall integrity, etc. And I'm also a big run for the wedge test. The frog wedge test is where 2 centimeter wedge is set underneath the frog. The horse, the other opposite leg is picked up, and the horse has to bear weight fully on this wedge up through the frog. So I found it to be an excellent test for looking at navicular bursa or pain on the bursa side of the navicular bone. Next, you can use the toe wedge test, which is similar, except instead of under the frog, you put it under the toe, and now you're stretching the deep digital flexor tendon. You're obviously applying some toe pressure there too, but I think most importantly, you're compressing the navicular bone down into the tendon, and you're also stretching the tendon, looking to see if this causes the horse pain. And then, as Andrew indicated, the medial lateral wall wedge test. This actually puts torque or twist on the joint capsule of the coffin joint and the collateral ligaments of the coffin joint. And I found this to be an excellent test to help differentiate those and bring them out. As Andrew had said, you can have a horse that's got a very mild lameness, and you can exacerbate it and make it very obvious using these tests. And when I have a very positive test, that puts me on the proximal or the dorsal side of the navicular bone. Okay, next. So obviously the imaging the equine digit. We have so many different things that we can do. Radiography is the standard. You know, I'm going to take that. I'm going to take a number of different radiographs, and if I'm chasing something, then I'll take some more. But I want to get a complete look at all surfaces of the navicular bone and get an excellent image of that. So upright pedal views, in my mind, work really well. Also, love using the ultrasound down here any way I can to start imaging. The bottom image there, you see, that's a collateral ligament, looking for those. I've used thermal imaging to test circulation or even just the presence or absence of inflammation down in the foot. Scintigraphy is frequently used to looking at bone turnover, etc., osteoclastic activity. And now today, you got the MRs and you got CTs that you can take a look at and even get higher detail and learn more about the different tissues. Now, today I want to share with you something a little bit different. That's part of the imaging. Okay, next view. So I think that one of the most important views that we take is the flexor projection, because it allows us to see the flexor surface, the gliding surface of the navicular bone, lets us look at the medullary cavity. You can also see the synovial fossa that are there. Allows you to look at the wings of the third phalanx independently. So this image gives you a lot of different looks. But next image, please. But as Andrew said, you can have an image, you can look there. So what you can see on this image here is that that navicular bone really doesn't look too bad. You have a couple slightly, you see two synovial fossa there that aren't very impressive. The flexor cortex looks pretty smooth. Everything looks nice and even, looks pretty good. But about 30 years ago, a colleague and I, we were studying these cases, and we started to utilize iahexol radiopaque dyes to put in with medication. We started doing that because we wanted to prove that we were injecting the navicular bursa, and there wouldn't be any doubt about it. But once we put the dye in there, we realized that we could take this flexor projection and we could see so much more, to the point that I've started calling it the poor man's MRI, something that you can do in the field, and you can get a lot more information. So next, please. So, and here is one of those views. This is going to show us, you see the navicular bone, and you see the white line with the little marks in it. That's the dorsal surface of the deep flexor tendon. That white dye is in there, showing you the bursa itself. And each one of those little defects signifies small defects into the deep digital flexor tendon. And the surface is specialized here in the bursa. So, and we know from MRIs, we know from arthroscopy, et cetera, that there get tears in this area. Now we can visualize them. And in this particular case, I can see them. I know they're there. Over time, they're going to start to erode the flexor cartilage on the back. And actually, if you look at this view, you can see that, how there's the black line that you see proximal to the white dye is the cartilage thickness. And this cartilage is thinner than it should be. And in some places, it's the dye is juxtaposed to the bone. So that cartilage, even though the radiograph looked really good, the cartilage in this bone is in pretty poor shape. So for me, as I've followed up on some of these cases, this is another place we can have for looking at treatments. But let's go on to the next thing when we talk about treatments when we get one of these cases. All these Palmar foot pain cases are always really interesting, but in my mind, the number one and most important thing always is chewing. So that's the number one treatment. We can go ahead and click on that. So it's up at the top for me, and we'll talk about it more. But as you look at other treatments, there's a myriad of treatments for that. Go ahead and start clicking. You can have vasoactive drugs have been recommended over the years for the past 40 years. Warfarin, isoxaprine, the pentoxifylline. You've had different anti-inflammatories have been recommended. And some horses practically live on it. What happened? Oh, okay. Keep going. Oh, well, that's interesting.
Sorry, this just seems to be a problem with our PowerPoint. So give me 5 seconds and I'll sort it out.
All right. So anyway, we'll as we look at all those, there's a myriad. This makes it different. There's a myriad of different treatments, and everybody, I think every veterinarian that's ever existed comes up with their own treatment for Palmar foot pain, navicular disease, or navicular syndrome. I don't care what you call it. Rose is the same by any other name. And the reason there's so many different treatments is that there's no universal treatment for that, because these cases are all so much different. So in my approach is that I try to break it down. And what I liked about, well, the hydrogels are probably the newest of the treatments. We've got all the regenerative therapies, and they certainly have their place and help. But the beauty of the hydrogels, in my mind, is that they can fill in some of those tissues. Okay, we can keep going with our list. Hyaluronic acid, glycosaminoglycans, bisphosphonates, the hydrogels, and when worse comes to worse, you can always do surgery. And let's go on to the next one. So we're going to come back to those hydrogels. So what do I consider if I'm looking at shoeing? I go through a process much like Andrew's, but I find not all horses have a negative PA. A lot of them have, they're broken the other way. It's a rare spot. A lot of horses have medial lateral imbalances. So as I look to shoeing considerations, go ahead. Number one is to correct pre-existing problems. That's why I want to do an analysis. I find out here's a horse that you can see with that has a flare to the foot. So that foot actually, I like to call it a half gainer. It's got a little twist to it. And you've got to figure that one out. You need to use all weight bearing structures, which is the same as Andrew indicated when he's using the pour ends. And I find they work really well. One of the issues though that was talked about was excessive pressure on the frog. So one of the very important tests for me as I'm looking at what shoeing I want to use is using that frog wedge test to tell me how much frog pressure can I place on a horse. Because I think when we start using these materials where we can spread the weight out to, spread the weight out to that entire foot, it can really help the concussion on these horses. But and the frog, I like to put a pressure on the frog if I can. But if that horse is really sensitive on the frog wedge, it's something I'll avoid during the shoeing. But when I can, I use every weight bearing structure or use as many structures as I can. Always try to allow for hoof expansion. So that means using fewer nails, even though they put 8 holes in every shoe, doesn't mean you need to fill them up. You just need to use what you need to use in order to keep the shoe on. And I also want to encourage, so I've oftentimes bevel the heels so the foot has a tendency to slide to the outside. And as Andrew had indicated, decrease the work of moving the foot by moving that break over. I like the horse to bear weight on all the wall, but I can take that shoe and I can bevel that shoe and move where the horse starts to make its breakover or unrollment, whatever you want to call it, sooner to just take some of the work of moving that foot. Go ahead, next slide. So now to the hydrogel in this particular case. Because of that tendon fraying, you have a roughness there. And yes, I've done endoscopic surgery of that, and you can clean them up, but you can never make them smooth again. And for me, the hydrogels, this is where they can come in. We've seen that they can fill in defects. They can restore a surface to make it more smooth, like it was when it started. So my technique for injecting the bursa is to go between the bulbs of the heel, just above the cleft, above the frog, parallel with the ground. I use a 3.5-inch 20-gauge needle. It's styletted and it's a spinal needle, so it separates the tissues in the tendon. It doesn't cut them like a needle would. But once I've got the needle placed, and there it is, I'll go ahead and take a lateral radiograph to confirm the placement to see where it's at. And what I want is right here, just like this. I want that needle exactly in the middle of the bone, or any place along the flexor surface, fine. But this part right here, this is the sweet spot. There's no doubt that you're going to be in the bursa when you make your injection, etc. So I inject the hydrogels in there. I've normally been injecting with 2 mils. The bursa only holds 4 mils, so I might be a little bit pushing the pressure side of that. And occasionally you'll have a horse that responds, doesn't want to put their heels down afterwards. But I find if you come back and you block that horse and let them bear full weight on it, walk around with the hydrogel in there, they get used to the pressure, or it disperses it better, and then the horse goes off. And it appears that it has this a smoothing. It smooths out those defects, so it makes for a better gliding surface again, whether it's in a bursa or a joint. So the hydrogels for me have been a real game changer in dealing with a lot of different problems of the joint and bursal surfaces. And I think that's my last slide there anyway. Yeah.
Thank you both for that. Basically, from now, we'll open up to the floor. If people have got questions, just raise your hand and I can turn off, allow your microphones to work. So yeah, like I say, if you want to come through, that'll be absolutely fine. Actually, we do have a question from the floor straight away. This is for Andrew. Are you medicating the hydrogel into the coffin joint or the navicular bursa? And that's from Annabelle Trainer.
G'day, Annabelle. Absolutely, we're doing an intra-articular into these. Tracy's just described the technique there for the bursal injection, but these cases that I picked there and presented today, we used intra-articular technique. So that's with that 21 gauge, 1.5 inch, just dorsal midline, 10 mil north of the coronary, and we just slide that vertically straight down and you'll get fluid nearly straight away. It's a fairly simple routine sort of an injection, but we use a whole syringe of Arthramid for those cases, and then, as I mentioned, we repeat that again in about 4 weeks.
Cool. And Jenny's got a question, so I'll just open up for her microphone.
Oh, yeah. I could actually have several questions, so I'll cycle through. But first question is, as far as the impression material, or in the U.S., a lot of farriers like to use the dental impression material, and the soft one seems to have pretty good results. Do you guys have preferences over? I mean, I realize that Dr. Watts, you have your choice, but do you dislike dental impression material or magic cushion in particular? Thank you.
So thanks, Jenny. The reason I've chosen the CS is because the dental impression material, for it to be effective, you've got to virtually use a bar shoe to hold it all in there. And we're trying to get away from using the bar shoes so we can actually, and with the dental impression material, I feel it's difficult. And with a bar shoe combined with the dental impression material, I find it very difficult to be able to judge how much pressure we're putting on that frog. And as Tracy mentioned, variable pressure on these frogs clinically. And so it is very important for a result. And too much is, can be crippling, and too little is not enough. So every horse is different. When we tape that foot up and pour it in, we tilt the foot to get as much in the heel. Sometimes we like a little bit more heel mass in that CS. And so we're able to adjust that while it's in that flow state for about a minute. And then, then we see again what the horse is the one that's the decider of how much pressure we've got in there. But if we've got the wrong pressure, we can take it out. The other thing is this CS is quite workable. So it's quite durable. Without a mesh in there, it'll stay in for 4 weeks without a trouble. We've had them go 6 weeks without too much trouble. And even when we start to bring them back into work, it's a very durable material. Just a sideline on that, sometimes if you've got one of those deep sulcus frogs, we put a little bit of dental impression material, maybe 5 mil deep either side of the frog, and that prevents that clefting, that ridging. When you pull that material out at the end of that cycle, it can get quite firm. So the 2 ridges that are either side of that frog, the dental impression material just masks it, rounds it off, and prevents that ridging happening.
And I think that's a really good point. I've seen a couple of horses come up sore over time when they whip the deep sulci, because they actually the material can actually get really hard and bruising deep inside into that frog stay area. So filling in those gaps. We use quite a bit of dental impression material. It's usually done underneath a pad. Depending on what you're using, I try to work with different farriers. I work with different farriers, so it's a little bit of a farrier's choice. I don't like if I'm not going to shoe it myself, I can kind of give them a little bit of free hand, but try to direct what I want. And if they're comfortable working with that, we will start that way. But if it's not working, I'm usually going to come back to the EquiPack. I like the EquiPack because it keeps things simpler. No pads, no nothing to make the shoe loose, etc. I think you can get a more firm fit. If you want to take pressure off, you can use a Dremel to remove pressure off the bottom of that, and it's a more even surface. But you work with the individuals you have and with what they got and what they're comfortable with, and we do it.
Thank you, gentlemen.
You're welcome.
Okay,
Too
we've
easy.
just got a question from Sarah Daly. Can you read the questions, Tracy and Andrew?
No.
Okay,
Off the chats.
off the chat, yeah.
So
Okay.
I can read it. So from okay, we got number 1 done. So the second one is, I have used it's from Sarah Daly. I have used Arthramid for the last 5 years and found it to be 50-50 successful for small joints like coffin joints, pastern joints, and tarsometatarsals, but no success for fetlocks at all. All of my cases would have blocked to intra-articular analgesia prior to treatment. What are your success rates for coffin joints? Side note, I also always modify shoeing as first-line treatment for my foot cases.
Do you want to take that one, Tracy, or?
Sure, I'll take it. So
Yeah.
when I'm using a hydrogel, and number 1, I want to make sure I don't have any inflammation left in the area, because the hydrogels are not inflammatory. So you need to have some type of anti-inflammatory, either systemic, or I've been known to inject the joint and then come back with the hydrogel. The hydrogel's effect is mostly in, it's cushioning everything. It's smoothing those joints out. It's helping the lubrication of the joint. There's a company that's coined the term osteocushion, which I like because it sort of explains a lot what happens with the hydrogels in there. It cushions everything, but they're not anti-inflammatory. If you've got any inflammation, you need to have the inflammation gone. I've come back with fetlocks where my injection has got me 80% of the way to soundness, and the hydrogels have put me to 100%, where the horse is really back to normal. So it's using your whole toolkit to take care of what you need to take care of. Does that help? I hope.
Yeah, I'd probably just like to add to that and review what you were saying and what I believe the case too. Mechanical for coffin joints, not for fetlocks, but for coffin joints. Focusing here on coffin joints, but for coffin joints, I absolutely find that you have to have that shoeing right. That's why I have that first 4 weeks where I can evaluate that and try to get some hoof growth, coming down. I need to get the mechanical balance right on that foot. If I can achieve a mechanical balance, I think I'm already taking a lot of inflammatory pressure off the back of that joint. And I think that enables more success rate with my Arthramid or with the hydrogels subsequent to it. I think the fetlocks we might leave out for another discussion, because so many varied presentations and results that you can get with that. And it's also to do with timing for work. I think if you're going to do these hydrogels, I think you need to stipulate that you've got to have 4 to 6 weeks off for this horse. It is not to go back into work. I think it seems to defeat the purpose of it. I don't seem to get the same clinical efficacy if the horse is going to get put straight back into work. They must take that time off for some sort of relief. And I do use systemic anti-inflammatory symptoms.
And I think that's a good point. Before with Triumph, when using triamcinolone, hyaluronic acid, and it's a couple days off and you're back. I've used hydrogels now for a number of years, and I can get away with that a little bit, but to have its most effect, you don't need to be resting, but you need to have a lot of reduced stress on the joints. So I like walking. Walking is a great exercise no matter what you're doing, and that can help a lot. But the slipperiness of these hydrogels in there, I even worry. I've had long talks with some of the companies about, I wonder if you get them back to work too fast and it's so slippery and you have a joint capsule that has some issues, you get too much movement in that joint and you get a little extra strain. But if you allow it to have its time to get in there, mature, because they bind to the other structures. And if you don't give them time to start binding to some structures, I think that's where you might be getting into some trouble. I know number of these, the hydrogels are doing further research to find out more of what they do, and I'm anxious to see it because they're a really good place in our tool chest. And some of them I've even, well, we don't need to go there today. Okay, Andrew, there's a question here for you from Jody Trier. She wants to, do you find the poly shoes a lot better than alloy for concussion and allowing the hoof to be more flexible?
Yeah, okay. Thanks, Jody. Look, we've had numerous cases now where we've shod the foot up with an open-heeled alloy and poured in our sole pack, and we think we've done a great job, and we've patted ourselves on the back mechanically, and we've been unable to appreciate any change in the comfort of the horse. And those horses, you know, I always say the horse is right, it's not us. So we pull it all off and start again, and we've reverted those horses we've changed them back over to a poly. And again, just making sure that breakover is right. On that lateral, I'd said there before, you know, that lateral, we had 30 mil of toe in front of the tip of P3. So pulling him back 3 centimeters for breakover makes a significant difference. But I think the cushioning capacity is worth talking about. That's a Coston shoe, that poly that we're using down here. It's the one that we seem to be using the most. And the classic examples, you put a steel on an anvil and you bang it with a hammer, and you put an alloy on the anvil and you bang it, and you get a little less rebound. You put that poly on and it just absorbs it and does a great absorbative job. And I think concussion in these Palmar heel pain horses is important, no matter what sort of discomfort they're going through. And if there's any way we can reduce that concussion, you know, I think it's worth exploring. These shoes are starting to take off in the trotting world here. We've had some remarkable changes in the paces here in their performance. So I think it's watch this space. I think it's a space that we really need to be aware of and explore the options. And they're just so easy to work with. And the other advantage with the poly shoe is obviously that Equipack CS is a polyurethane. So poly binds very well to poly. So it sticks really well to the inside circumference of a poly shoe, that sole pack. So it makes a really durable sort of solution that's ready, quite quick to apply and easy to use.
John Miller's got his hand raised, so I've just opened up his mic if he wants to ask his question.
Hey, Andrew, can you hear us?
Hey, John.
Hey, mate. Hey, so I got a new one. This is one I was actually going to ring you about, but I thought this would be the perfect opportunity to ask. So I got a new client. It's got a fracture on the medial side of the navicular bone, but lateral, the foot is very high-low, and the lateral measures 3 mil shorter on the lateral side. On the lateral side. How do we approach that without putting too much pressure on the fracture now?
Look, I think the first thing you've got to do, and I can sit down with you and go through those in more detail, it's probably going to be more accurate. But basically, as Tracy alluded to early on, I think the first thing you've got to do, whether you've got a unilateral lesion or a central core lesion, I think you've got to have symmetrical foot balance. So the first thing I address is obviously the symmetry of the whole foot and try and get that navicular sitting as level as possible. And then sort of address your breakover and go from there. But you know, have you put some shoes on it yet, John? Or
no, mate, I haven't seen it yet. Just had a phone call from the vet. Okay.
Well, we can maybe take that offline and have more detail. But definitely, and I'll throw that back to Tracy too as a question. A unilateral palmar fracture, we tend to sort of level them out as much as possible. But what are your thoughts there, Tracy?
And it's a navicular fracture or a P3 fracture?
Navicular fracture.
So I've had a lot of success with the technique. You balance it out first. You make sure there's no twist on that thing because that starts to, because the bone will twist because the attachments of the ligaments, which puts pressure on it. But I have a technique where I radically raise the heels of this foot, and it takes the pressure of the deep flexor tendon and everything, and the ligaments that attach to the bone, takes the pressure off of those. And it pulls the navicular bone from a weight bearing area off of that weight bearing area and allows the time to heal. And so essentially, we raise it up about how much is that? It's about maybe 4 centimeters. And then each reset of shoe each month, you take a centimeter down until you get them back to normal. And as you do that, you get a really nice fibrous union. And the vast majority of horses I've had have been sound by the time I get them back down. So you raise them up, and over a series of months, you take them down 1 centimeter at a time, and it works really well because it gradually loads out and stretches out any adhesions you might be getting in there too. So
is that still with a square toe there, Tracy? Like
you can still have a square toe. Yeah, I don't use a lot of bar shoes on these because what's a bar shoe going to do for you with a navicular bone anyway? And I'm not the biggest fan in the world of bar shoes, but I've been accused of hating bar shoes. I don't hate bar shoes. I just don't find a lot. I don't have a lot of use for bar shoes. Yeah. So another one for you, Andrew, and well, she's Michelle Hennessy's asking about. She's interested in the nutritional aspects. Well, and which gold supplements gave the best growth? So see, I'm still back. I want some of this in the States, mate.
So, we're getting similar growth with all 3 products. The bone one tends to address bony lesions in navicular and in addition to the hoof growth, and then the total has a vitamin and mineral mix as a component as well. So the total is fantastic for those laminitic full wall resections that we've got locked in boxes that we need to get remarked. Like we need a new hoof yesterday, but we'll put those horses in a box and feed them bran mash and teff for up to 12, 14 weeks, depending on how much regrowth. And we've got some good sort of data on those. But, we're getting really substantial growth, and I really just need, for navicular horses, I just need that heel mass as quickly as possible. And I just find heels are so much easier to grow than dorsal wall and laminitis. And usually these quarter horses respond, because usually quarter horses, but usually they respond so well. We can grow down heels in 2 cycles. We can have a long flat heeled foot, and we can sit it up. And that navicular fracture that we had, we jacked that up 20 mil. And same as you do, Tracy, we do the same thing. We jack them right up to get maximum relief and slowly let them down over a period of time.
Yeah, okay, we got some more questions. I got, Sarah Daly has put one in here. She says, I always inject triamcinolone 2 weeks before the Arthramid. Otherwise, the Arthramid has not worked it well. And I think that's that inflammatory component that we're talking about. You got to knock out the inflammation in these things, or the hydrogels are only going to give you really super lubrication and smoothness, but that doesn't knock out inflammation necessarily.
Just a question for you, Tracy. Do you think that triamcinolone, I've stopped using triamcinolone in these navicular cases for the last couple of years. I gave up on it. I thought I was actually, because they seem to bite me about 8 to 12 months later, and they seem to regress. And I'm just wondering whether I get temporary relief out of it. I'm causing some sort of secondary degeneration in the joint with the triamcinolone. I'm unsure of it, but it's a gut feeling I get.
So I'll answer that by, triamcinolone's our friend until it's not our friend. And it's a really potent anti-inflammatory. It has a place, but once we've done that, I think we need to rely on the mechanics. If there's something, we get the mechanics fixed and there's something that's still creating this inflammatory process, we need to figure out what that is and try to address it as well. I mean, if we just put triamcinolone into that, or the corticosteroids into that, we're just going to get degeneration. And I'm old enough and have had enough joint injections. I'll tell you, you feel really good after a triamcinolone injection. And maybe too good, because you feel a lot younger, and so I think there's some real danger in that, and I try to caution some of our younger sports medicine people that see this initial benefit of steroids, but it's like, yeah, I completely agree with you, but you have to have caution. So there's a good and bad side of every coin and sword, or whatever you want to talk about.
It's just an extension to Sarah's question. For everybody's information, I've actually turned on the chat messaging now. beforehand that was turned off, hence why you could only use the Q&A. But Sarah's additional question, if you could answer that, which is the injecting contrast into the bursa,
Oh, yeah, here we go.
just because we don't have MRI in New Zealand.
Yeah. Oh, you don't have MRI? Yeah, you don't need it. Okay. I'm going to get talks about that after this. Okay, what other lesions can you see when injecting? Oh, I've got a whole hour-long lecture. What I've learned from this is so interesting. You can see, you can obviously see cartilage erosion from the flexor surface. You can see those those fibrillation into the tendon. Some of these actual tendon lesions that show up in MRIs, they communicate with the bursa, and you see the dye going up into the tendon, which the beauty of that is now you've got an easier way to treat that because you got a direct route into that tendon for regenerative medicine or something like that, if that's what you're interested in. But there's a couple of things I've seen that well, it hasn't been reported on an MR, and I think the reason is because these injections into the bursa are dynamic. I'm filling the bursa up with a contrast and fluid, and so I've seen cases where I can show where the bursa. This is hard to explain without showing pictures, but the bursa gets larger on one side. It's like the whole thing's twisted, and the only way I can see that happening is that's an indicator that the annular ligament, the distal annular ligament of the foot, has been partially torn, allowing that. So when on that flexor view, when you stretch that tendon back, it should be right against the navicular bone. And when that annular ligament is injured or torn, it allows the tendon to twist, and you can see that because one side of the bursa gets wider, very clearly wider. Really interesting. Then the other one that happens is that you can get soft tissue tears, medial or lateral, into the bursa, into essentially the neurovascular structures make up the medial lateral borders of the navicular bursa, and you can get tears into that tissue, and you'll see the dye leaking out. And over time, I follow these long. Many of them will go ahead and heal. Not all of them will go ahead and heal, but because some of them almost set up a neuritis around there because you have this chronic inflammation. Now, try different things, and I was anxious. I really wanted to try a hydrogel on one to that, see if it would plug the leak. And I haven't seen one since I've been, using the hydrogels in this method. So yeah, somebody sees one, it'd be worth a try. But there's all sorts of things that you can see there. You can see changes in the proximal ligament. You can see communications. They're fairly rare, but whenever I see a communication from the bursa into the coffin joint, you'll see those. Those are always ones I go back and I start looking at the collateral ligaments, etc., because I think there's an indication that you've had a joint capsule injury. So I do even more diagnostics when I see that. I've seen tears between the bursa and up to the tendon sheath. Those actually heal pretty fast. You can that may cover it, but okay. You'd be surprised what you can see, and that's why I call it a poor man's MRI. I don't see all this subtle stuff in the pastern that they're seeing, but I get a great view of the navicular bursa, and can find a lot of pathology there.
Okay, so if we jump back to Mark's question, what time frame interval would you apply between IA, Triam, HA initially, then a hydrogel for a coffin joint?
I'll leave that one for you, Tracy.
Yeah, well, in my case, because I'll still come back and I'll use some HA and triamcinolone, but I'll look at a horse, and once they're improving, I still follow up and do flexions and stress them out, and if they're still having pain coming back, and I think the hydrogels can be there to help prevent a lot of stuff, because they're improving the lubrication, they're filling in, especially if I'm suspicious of defects in the cartilage, or some of these, particularly with horses in the coffin joint, where I've seen collateral ligament damage over time. and I can't prove this, but and just working with these horses clinically over years is that they get stiffer in the joint. And I think the hydrogels improve that because they can bind to that synovium. They allow a little bit more comfortable movement, because what I've seen, a horse with a coffin joint injury, particularly collateral ligaments, where that gets stiff, over a few years, it seems like the bursa starts taking on, gets damaged more. And I wonder if that's because there gets to be more movement in that area as the horse lands, et cetera, putting pressure on there. You know, this needs a lot of biomechanical study, so I'm putting cases together that way. But how much time? Probably come back in the same set of shoes, and if I think it's there and I'm putting it in to help the lubrication movement, I'll wait a couple weeks and do it. Otherwise, yeah, that's been my usual MO. I'm trying to think. Yeah, come back and I have no problem with doing that for a couple weeks. I just want to be sure that I've got that inflammation knocked out, and then come back with this, or the cases where I've just gone on, because the hydrogels. The other thing you can do with the hydrogels, and then I may be speaking out of turn, because Arthramid, I think, specifically says they don't want you adding anything with them, but you off the record, and all Arthramid people should close their ears. You can, and it works.
Yeah. Okay, so we've got one more question in the Q&A from Jenny. For say a racehorse with crushed heels, is there any research or attempts to inject hydrogel into the digital cushion?
Not that I'm aware of.
I did. When a company in the States that makes a hydrogel first brought it to me, I looked at it and saw the product and go, I wonder if I could rebuild a digital cushion with this. And so I took a couple horses with crappy feet, and I injected, and I used quite a bit of the material, and it was positive enough that I wanted to do more research with it, but it takes like 3 or 4 syringes of the stuff that sort of give you the amount of material you need. And I would want some more research behind it before I started doing it and charging clients for that kind of money that for rolling the dice. But I like the idea. You obviously thinking ahead, liking the idea too, because I've been trying to figure out ways to rebuild digital cushions, and I think these might be a method to help do that. But I haven't got the formula for you.
Okay. So
just a quick note on rebuilding those long flat heels. We've had a lot of luck with using superfast and building from about 10 mil down from the coronary band. Rather than putting wedges on these horses, we tend to try and build the foot and build it to where we want it and start to force. And it seems to act like instead of applying a wedge to try and build them up, which just gets you in more trouble, I think building the heels with superfast seems to build them up medially and laterally and get them up off the air. And then we can pull that shoe back and take some depth out of the toe, and we start to get headed in the right direction. We can sort of try to retrain the foot. We can do it quite successfully on younger thoroughbreds. It gets harder as they get older, but if you can catch them on a spell when they're heading out, we can build those heels and retrain those feet. We've got a couple of research ones that we've been able to follow through. We've got some good documentation of retraining those feet to grow where we need it to grow.
So Andrew, when you do that, have you been able to improve the thickness of, say, between the dip between the bulbs of the heel and the thickness? So when you put your fingers in there on that frog and that you get that feel for the thickness of the digital cushion. Can you improve that? Not necessarily the heels, but that thickness area?
I don't know whether we're changing the digital cushion. I hear you on that. I don't know whether we're changing the digital cushion. I think we're trying to realign the tubule direction more than anything else. I don't think we're affecting the digital cushion. I think we're just trying to retrain those tubules.
Yeah.
But that tends to alleviate a lot of the inflammation that's secondary to those rolled over bars that's coming up through that cushion. So it says once we get that bar sort of sitting up and it's got that nice V to it ventrally, we seem to get a lot of relief of that heel pain. That's a whole nother lecture.
Yeah, well, yeah, no, it is. Yeah.
Yeah.
Okay, well, we've just ticked over an hour anyway, so I think obviously everybody's got busy lives and that sort of thing.
It was fun.
So if you've got any other questions post the seminar, certainly email them through. We'll try and answer them the best we can. I'll also the recording we'll email out as well, just so you can refresh and have a look at a later time. But yeah, thank you both, Dr. Andrew and Dr. Tracy, for coming on today. It's been a very, very informative session for everyone, I think. But yeah.
Thank you, guys. I really appreciate it. Thank you very much. Thanks, Tracy.
All right, you bet. We'll see you.